Okay, so again, I was asked to talk about a frontline case and a toxicity case. And so this is what we'll do. We will go over a frontline case and the choices of therapy and toxicity management with the second case. Let me just minimize this. So this is a 38-year-old male from Qasim with no prior medical problems. He presented there in Qasim with enlarged lymph nodes in the neck early 2019 in January. They did a workup and that showed leukocytosis, mainly lymphocytes. Flow was consistent with CLL. They did a bone marrow biopsy and it was consistent also with the CLL. So he was referred to us for management. At the time of presentation in late January 2019, he had normal hemoglobin, platelets. He was asymptomatic beside the enlarged lymph nodes, okay? So at that time, we had access to immunoglobulin mutational status. So we sent that and it came back as unmutated. So a few points about the mutational status. As you know, this is a one-time event, so it's not a dynamic event, it's static. So the clone that developed CLL is either mutated or unmutated, okay, from the get-going. It doesn't change, okay? So if you have unmutated, it does not become a mutated and vice versa, okay? And this is why it's okay to check it, even if you don't have indication for therapy, because it's a static and it'll remain the same. What does it mean? When you have, the B cells, they mature in the germinal center and they acquire mutation when they are exposed to antigen. So that's how they become hypermutated, And when this maturation happens, that means these cells are more mature and the prognosis is better. The unmutated, they do not undergo the germinal center mutation and education, and their outcome are worse. So again, he didn't have any of the IWCLL criteria like constitutional symptoms, marrow failure, autoimmune cytopenias, massive splenomegaly, massive lymphadenopathy, progressive lymphocytosis. So we did watch and wait, which is still valid even in a high-risk patient like this, young and having unmutated immunoglobulins, okay? So this is what we did on him. Unfortunately, shortly after that, he comes back to the emergency department in April 2019 with severe abdominal pain. A CT scan done in the ED shows a big conglomeration of lymph nodes, more than 17 centimeters in the abdomen, causing the pain. So with any progression like these, the first thing we do is we look for Richter transformation. And the way we look is we send LDH. His LDH was elevated. We do a PET scan. The PET scan was not supportive of Richter's, though, because most of the lymph nodes had the same uptake, so there was no area with different uptake or a lot more higher uptake. So, however, we took a lymph node biopsy from the inguinal lymph node that had the highest uptake, and that inguinal lymph node biopsy came back as low-grade B-cell lymphoma, so no evidence of Richter transformation. Now, the patient has indication for treatment, so now it is indicated to do mutational analysis. As you know, at baseline, marrow is not required for diagnosis by guidelines. It's okay to have it. And the mutations should not be sent, actually, because the mutations are dynamic. So you can check your patient in January where he did not have any indication for therapy, and he would have, let's assume, normal fish. Then when the treatment becomes indicated, you treat him based on that fish, and this is inappropriate because these mutations, specifically the P53, can happen over time. So whenever you decide the patient needs therapy, you have to do them in the frontline or relapsed refractory to make sure he did not develop any of these, okay? When we make our decision, this is how we make our decision. There are disease-related and patient-related factors, okay? So the disease-related factors are mainly the mutations, the high-risk mutations, and specifically the 17p, because as you know, if 17p is present, then these patients will not draw any benefit from chemotherapy, and it's not at all recommended to give any chemotherapy, okay? Patient-related, usually the age, creatinine less than 70, bad performance, or high comorbidity index defined by a CIRS more than 6. So if the patient has any of these will make him fludarabine ineligible, okay? And this is how you base your decision. So patient-related and disease-related. And then once you put all of this together, you end up with this tabular view of the scenarios and therapy proposed. So in the front line, you either have 17P or non-17P for the fit patient. And in the front line unfit, also you split your disease into 17P, non-17P. So for the front line fit, 17P deleted, you cannot treat with chemo. It's not indicated. It doesn't work. So you have to have one of these targeted therapies. For non-17P, so chemotherapy, your patient is fit, and non-17P chemotherapy becomes an option, as well as ibrutinib, which is studied in this scenario. Okay. Frontline unfit, same 17P only targeted therapy. Non-17P you can treat with chemotherapy here. And because the patient is unfit, you have to go to BR or chlorambucil Gazyva, plus all the targeted agents are approved here, okay? So this is how we make our decision in the front line. This is the NCCN guideline for frontline therapy for 17P specifically here, okay? So as you see, all are targeted therapy, not chemoimmunotherapy. And ibrutinib in the front line, you know, whether it is fit, unfit, has most of the data because the company has tested the drug against all the standards, basically, like in the RESONATE-2. So this was a phase 3 treatment naive of ibrutinib against chlorambucil and ibrutinib 1. The EAT-1912, the ECOG trial, it was a phase 3 trial, treatment naive, IR versus FCR and IR1. Alliance trial, also phase 3 treatment naive, IR versus BR. This is in the fludarabine unfit patient. The Illuminate trial was a phase 3 treatment naive, elderly, ibrutinib Gazyva versus Gazyva chlorambucil and ibrutinib 1. And also, very important to know that patients, while on ibrutinib, they can develop the C481S mutation, which carries resistance to ibrutinib. So if you have a patient on ibrutinib and develops resistance, he may have developed this mutation. So this is our patient. That's how he presented. We started his therapy here in April 2019. And as you see, his count jumped initially and then went down nicely. And this is typical of ibrutinib. When you start ibrutinib, there will be a mobilization of the cells from the lymph nodes to the blood. And you get leukocytosis, but then this persists only for 2 to 3 months on average. It can be longer, but the average is 2 to 3 months, and then the counts normalize. So on this patient, we also did HLA analysis because he's 38, unmutated, and P53 mutated. So super high risk. So you get yourself prepared for the possibility of transplant in the relapse refractory setting. And he did have a fully matched 10 out of 10 sibling, this third sibling, okay? We move on to the second case. So this case is a 78 years old from Jizan, presented in April 2016 with fatigue, bone pain, malaise for 3 months, and enlarged neck mass. He had a CBC that showed leukocytosis, mainly lymphocytes, and he was referred to us for further management. He doesn't have any medical problems. He had hernia as far as surgeries, and he doesn't smoke or do drugs. He lives in Jizan with wife and kids, has 10 kids. He's a retired teacher. No family history of malignancies. So we did a blood smear, 7% prolymphocyte, and these are expected in all cases of CLL. However, when the prolymphocytes are beyond 55%, then here you start thinking about PLL rather than CLL. He had smudge cells, typical of CLL, lymphocytosis, and mature lymphocytes. Flow showed typical B cells, CD5, 19, 20 DIM, CD22, CD23, and kappa light chain restricted cells. So we have a confirmation, and beta-2 microglobulin was elevated at 6. Okay, so beta-2 microglobulin usually tells you about the burden of disease, and when it's elevated, this means there is a high burden of disease in the body. Bone marrow biopsy was done. It's not required again to establish diagnosis, but it's okay to have it. CT scan was done because the patient had indication for therapy, so we need to have a baseline compare to. FISH was done again. Here you have indication for therapy, so you check FISH, and it was positive for trisomy 12, which is associated with a good prognosis. And the patient was started on ibrutinib given his age, and ibrutinib was the only available option in 2016. We did not have venetoclax or acalabrutinib and the new targeted therapies. So he was started on ibrutinib for the progressive cytopenia and for his constitutional symptoms. And this is his CBC. As you see, when we started, the count went up a little bit, then normalized, and his hemoglobin was low and then went up to normal. However, when he came in here in 2018, so a year and a half after starting his therapy, this was his blood pressure, 186/78, repeated and confirmed high. So we kept him in Riyadh and we started checking his blood pressure, and it was elevated most of the time. Going back like a year before that, and immediately before ibrutinib therapy, his blood pressure was normal. So it did develop with ibrutinib. It was not picked up until 2018. And side effects are very well known with ibrutinib, and these are what we call off-target inhibition by ibrutinib. So ibrutinib inhibits B-cell receptor, but does inhibit other receptors and enzymes like CXCR4, and this is what causes lymphocytosis. The non-TEC enzymes such as EGFR and VEGFR, and these cause rash, diarrhea. The other one causes hypertension. PI3K AKT causes AFib, and BTK enzymes cause bleeding. So this is because the off-target inhibition, again, of ibrutinib rather than the B-cell receptor inhibition. And here's a summary of the side effect that can happen with ibrutinib from the largest, the earliest trial like RESONATE 1 and 2. So this is a cumulative incidence of side effect. As you see, in red is grade 1 and green grade 2, yellow grade 3. As you see, bleeding, mostly it's a grade 1 and less likely the others. This is diarrhea, fatigue, rash, arthralgia, hypertension. So as you see, a good number of the hypertension patients are higher grade rather than the other patients. Same for AFib, okay? The good thing about hypertension, even if it's higher grade, there was 0 dose reduction and only 1 patient had dose discontinuation because of hypertension. So it's not a frequent cause of interruption of therapy. So how do we deal with ibrutinib toxicity? If you have a non-hematologic toxicity more or equal to grade 3 per CTACE criteria, then you have to hold your therapy until the toxicity goes back to baseline or grade 1. Then you reinitiate at the same dose, okay? So you do not dose reduce. Now, if the toxicity does reoccur with that, the same toxicity like hypertension happens again, then you have to reduce to 140 by 140 milligram, 1 pill. And if it does recur on the 280 milligrams dose, then you go to 140. If it does recur on the 140 or doesn't improve, then you'll have to stop the medication permanently. So this is a tabular review on how to dose modify. Again, first dose first toxicity you do not reduce. Second, you go down 1 pill. Third, you go down 2 pills. Persistent after this on the lowest dose, which is 140, then you discontinue. This is the prevalence of hypertension. It's one of the it's the only actually side effect that has an increase in incidence as the time goes as compared to the other side effect. The other side effect actually they normalize, okay, or they go away as time goes, but hypertension, as you see, goes up. This is very typical, and usually it's easily manageable. Again, there was 1% only of the patient who discontinued ibrutinib due to hypertension. You treat as any regular hypertension, okay? You check the cause of hypertension, and it is indicated to treat because, as you know, people on ibrutinib are prone to other cardiovascular problems like bleeding and AFib. And you can use any hypertensive. You just need to avoid the CYP3A4 antihypertensive, as these increase the concentration of ibrutinib. So what's the frequency of hypertension, grade 3 hypertension? It was a quarter in both frontline and relapse refractory. So if you have a frontline patient started on ibrutinib, you expect a quarter of them will develop hypertension, same in the relapse refractory. Okay. With that, I'll finish and happy to take questions.
Dr. Riad, can I ask a question? No.
Sure.
Regarding ibrutinib-induced hypertension, we've read the best option is calcium channel blocker. Is this correct?
Well, yeah, because it has the lowest interaction with the CYP3A4. Okay. However, ACE inhibitors are okay as well. So they're not absolute contraindication. They can be used. They're very mild inhibitors of CYP3A4.